I'm going to talk about visualizing the perfusion of the brain with CT and MRI. And with some basic knowledge, you can reason what the normal perfusion of the brain should be. The brain receives about 20% of the cardiac output, so 1 liter per minute, and weighs about 1.5 kilo. So there's 17 milliliters of blood going to 100 grams of brain each minute. And this number is a little bit higher in gray matter than in white matter. You can quantify perfusion with CT, and you image at different time points after administration of contrast. You can draw a region of interest in the artery and the vein, and with this arterial input and venous output curve, you can calculate the perfusion of the brain tissue correlated to the attenuation. If you take a closer look at the curve, you can see different parameters. Contrast is injected at time point 0. There's the time to peak till the top of the curve. The slope of the curve is the cerebral blood flow. The width of the curve is the time that it takes for the contrast to get through the brain parenchyma, or for the blood to get through the brain parenchyma, so that's called the mean transit time. And the area under the curve is the cerebral blood volume. And you can visualize this by making a color map with red for the highest number and blue for the lowest value. And you can look at the cerebral blood flow, blood volume and mean transit time, and this is usually done in stroke patients, and we will come back to that in a few months. In oncology, MR is the primary imaging method, and there are also two MR perfusion techniques that I want to discuss. The first one is T1 based, and it's called dynamic contrast enhanced perfusion. And in tumors, there's angiogenesis, and these new vessels are leaky. So if you administer contrast, you're not only looking at the perfusion of the tissue, but also at contrast leaking from the blood vessels to the interstitium and extracellular space. So the curve of a tumor on MRI is composed of a curve resembling the CT curve, with the concentration in the blood plasm, and a curve of the leakage into the interstitium. And these two curves together give the curve that you measure, with a wash-in, a plateau that reflects both interstitium and blood plasm, and a washout. And from this curve you can calculate cerebral blood volume and the capillary permeability and make color maps of that as well. The second MR method is more often used, and also in our hospital, and that's a T2 technique. It's mainly T2 star. So you can see that the signal drops instead of a curve going up. And because you also have leakage of contrast, what is often done is that before giving the bolus for the perfusion, about a quarter of the contrast is given as a preload. So this leaks to the interstitium, then the interstitium is filled already with the contrast, and then you can truly measure the perfusion. And this DSC reflects the volume of the microvessels. Because we do not have an arterial input and venous output curve like we had at CT, you do not get the exact perfusion of the brain, but a relative perfusion, so you compare it, for example, to normal white matter. The big disadvantage is that it's a T2 star technique, so it's not applicable in hemorrhagic masses, either primary tumors or metastasis. And in the next vlog we are going to talk about glioma follow-up with MR perfusion to discriminate pseudoprogression and pseudo-response from true progression and response. Thanks.